closed is basically that A2 signal. And then the A3 signal is the passive filling, which causes some signal as the heart relaxes. And then again, that A4 signal is the signal that we're most interested in detecting. That is that atrial kick signal. So if we look at our algorithm from the actual algorithm, we have 3 blanking periods. So we have this PVAB, so no, we won't track it. And then we have 2 different tracking. So we have a kind of a dual thresholding scheme. We have an A3 threshold, which occurs early in diastole, that has set at a higher threshold. So it needs to be set higher so that we don't detect that passive filling signal, but low enough so that it detects that summated gallop signal that I showed you earlier. And so that's the A3 threshold that's used kind of early in diastole to help with higher sinus rates. And then later in diastole, we can have this A4 threshold, and we can set that much more sensitive to just detect the A4 signal and just make sure it stays above the noise floor and detects signals later in diastole. So that's sort of the core accelerometer algorithms. We have some automatic algorithms that automatically set those values. But on top of those algorithms, we have some other different higher level algorithms. So we have an AV conduction mode switch for patients with episodic AV block, where you might not want to be in VDD mode the whole time. We have the activity mode switch feature, which can switch to rate responsive pacing if we see a disconnect between the rate response and how we're tracking the device. And then we have a rate smoothing feature that hopefully we use to overcome intermittent periods of atrial undersensing. So if you look at this graphic here, you can see this is the rate smoothing operation. And you can see we're tracking fine here. We have AM, AM, and AM, and then we miss one. And so instead of going all the way back to the lower rate of 1200 milliseconds, we basically have the prevailing rate plus a rate smoothing delta. And that allows us to we have a little bit more undersensing in this device than you would have in an electrical sensing. There's a little bit more variability in the accelerometer signal. And so this helps us ride through intermittent undersensing. We also have a feature, it's called the AV conduction mode switch, that helps us for patients with episodic AV block. And our predominant mode is VDD, but then we'll switch to VVI 40 if the patient has conduction. And then if they go into AV block, we'll switch back to VDD mode. So this helps, and once we go into that AV conduction mode switch, we can turn the accelerometers off. There's very little pacing. There's very little accelerometer use. And so the device longevity gets really enhanced by that. And then if they do switch into AV block, we can always go back. The device will automatically detect that and switch back to VDD. We also have an activity mode switch feature, which basically is the rate response is running all the time in the device. Even when we're in VDD, the rate response is kind of in the background running. And if the rate response says the sensor should be, at 95 or 100, and we're only at 75, it'll switch to rate responsive mode. So it basically detects a 20 beat per minute difference between what the sensor rate thinks it should be and what the VDD tracking will be. And so that can be useful for times where the patient is very, very active, and if we're not quite tracking as well, because it does get tougher to track at higher sinus rates, because you have, the ventricular and atrial motions are superimposed on top of each other, and some of the actual activity of the whatever activity they do kind of gets superimposed on the accelerometer signal. One thing I should notice is this can be programmed on and off. Most people have it programmed on, and it really is only kicking in, 1 to 2% of the time. Also, that AV conduction mode switch can be programmed off or on, depending upon whether the patient has complete ART block or not. You can just turn that off. So one of the things is, we're not really recommending, you change the implant procedure. That's one of the really nice things about the Micra AV device. The implant procedure is exactly the same. So we're not recommending you search for a particular site to get best accelerometer signals. In general, it's more about the atrial kick than it is where in the heart, where in the ventricle the Micra is implanted. And we also have seen, that tether can affect the accelerometer signal. So some tension on that. So it's not always, clear before you cut the tether, what the accelerometer signal is. So we recommend just continue to do the normal implants, test the device in VVI. And then when you program VDD at the after you've done your electrical testing, there's an atrial sensing setup algorithm that will work and kind of give you a starting a kickoff to where AV synchrony should be. And so this atrial sensing setup will actually look at, and it sets up about 4 different parameters. It chooses what combination of the accelerometer vectors it can use. So there's a 3-axis accelerometer in the device, and we use combinations of those vectors to get the best sensing. And the setup test will find the vector that has the combination of vectors that has the biggest A4 signal. And then it also figure out starting points and ranges for your A3 threshold, A3 window, and an A4 threshold. One thing I would say is this A3 window end tends to be a little bit long in this auto setup algorithm. It's our first generation, and we maybe were a little bit conservative. So this signal, usually the auto setup maybe needs to be reduced by about 50 milliseconds on average from what the auto setup says. One other thing I wanted to talk about is the MAM test, which is this manual atrial mechanical test. And this basically is a press and hold test where you can press and hold and gather a number of signals. So in this particular example, there's seven cardiac cycles that were selected, and this is the 5th cardiac cycle, and you can switch between back and forth. And this basically, if you look at this signal, this is a simulated signal, but it kind of shows the A1, A2, A3, and A4. And you can use these different parameters and kind of set up the accelerometer signal, look at your P wave and make a decision. And so for this particular example, the P wave is occurring right here. And you'd really like to set that A3 window end between the A3 and the A4. And in this example, it's really kind of straddling this A4, and you really need it to be a little bit shorter. So for this particular example, we undersense, there's no AM here. In this particular, we just barely missed detecting, and we really need a little bit shorter A3 window end. And that's example basically showing this again. This is the exact same from the prior slide where it's just a little bit too high. And now we bring this A3 window end. So instead of being 830, it's 775. And that allows us to detect that and provide AV synchrony. So there's some adjustments, particularly on the A3 window end, that is usually done for many patients. We also have some sequence counters that can give you an idea of your AV synchrony. So you can look at the atrial ventricular histogram and see how many of these cycles were AM V-sense, V-sense only, or AM VP. And AM VP is a pretty good surrogate for how good the AV synchrony is. Now, sometimes you can have some oversensing where it maybe is oversensed, overestimating the value, but in general, it's a pretty good, if you don't have any oversensing, it's a pretty good surrogate for how good your AV synchrony is. And it also gives you how much time you've been in those different mode switch modes. So, the activity mode switch is typically 1 to 2% of the time. And then depending upon the patient's AV conduction status, this can be, 0% for an AV block patient, or somebody who has very episodic heart block, this could be very close to 100%. We also have an A4 trend. So you can look at how that A4 signal is adjusting over time, and looking for if things have changed over time. It's very similar to kind of the P and R wave trends that we have for electrical sensing. And we're going to be, I think there's at Heart Rhythm this year, we have an abstract that's looking at, from our CareLink database, the trend of how stable and how what's the typical value for a lot of patients. So I think I would just close now with just a little bit on, when we did these studies, we also looked at predictors of good AV synchrony, and what kind of echocardiographic parameters might suggest good AV synchrony. So this was a manuscript that was published in the Heart Rhythm Society looking at that. So in that, we created a model. So we had all these echo and imprint parameters from the different patients, And we wanted to see, both on a univariate and multivariate basis, what predicted who would have the best accelerometer signals or A4 signals. And so there was a number of different variables. We had 51 total variables, a lot of different baseline history, 16 different, what medications are used, where the device was located, and how long the device had been implanted. So in all our studies, we were downloading this algorithm into patients just for a brief amount of time. But some of the patients have been implanted, yesterday, and some had been implanted 5 years ago. So we had this really long time since, we had a good distribution of how long the people had been implanted. And that was good for understanding, how the accelerometer signal might evolve over time. One of the measurements we took was this TAPSE. So some of you may be familiar with the RV TAPSE, which is typically looking at the systolic excursion in the RV, kind of looking at how much movement you're seeing from base to apex in the RV. But we were also looking at the atrial component of that, or the diastolic component. And if you can see this first drop is really kind of the passive filling, that E wave. And then the second is really the atrial kick component. And if you see a nice atrial kick component on the RV TAPSE, that's usually a really good sign that the patient has good atrial function, and it's causing movement in the RV, and it's also causing the accelerometer's signal. So if you look at those 51 variables we looked at, all of these variables were associated with the A4, that's at a 0.1 level, and the yellow is the ones that were the most significantly associated with A4. They were associated on the multivariate level. And so if you look at this beta, the negative means it's inversely correlated, and a positive value means it's directly correlated. So the cabbage here, so if the person has a history of cardiac surgery, typically they would see smaller signals. And whether it's due to cannulation of the right atrium or adhesions following cardiac surgery, I don't think we know for sure, but we definitely have seen smaller. It doesn't necessarily mean it's not going to work. It just means oftentimes the A4 is smaller, and it can be a little bit more challenging to get good AV synchrony. The one thing we've seen across all our studies is this E to A wave ratio, and that's been a higher the E to A wave ratio, the lower the A4 signal is. So if you have E to A wave ratio greater than 1.5, then the signals are typically can be a little bit more challenging. And people who have E to A wave ratios of around 1 tend to have good A4s, and therefore a better chance at really good AV synchrony. So this is my final slide here. So one of the things is from this study is we can find that the A4 amplitude, is really related to atrial function. The device location was not a strong influence. We're still looking at that to see if there's a sweet spot, but I think it's really more about the patient's atrial function rather than where in the ventricle the device is actually located. And so, we had a pretty good predictor of in a presence of low E to A waves and low sinus variability, the AV synchrony can be often quite high. And we are, committed to continuing to do this study. We have the AV trial, which is looking at chronic AV synchrony. That study is ongoing. We've, are well on our way there. We have a couple other studies, bigger studies, a post-approval study that's going on in Europe and in the United States. And then there's also another study that's condition of approval for the United States Medicare that we're doing for the Micra AV. So we're continuing to study this, but and so far that we've been really happy with the results. So with that, I will send it back to the moderator.
Thank you, Todd. It indeed was informative. I would like to request the audience, if they have any questions, please post them in Q&A box. We will be answering them shortly. And now I would like to welcome Dr. Lawrence Epstein, System Director, Electrophysiology, EP at Northwell Health, to be taking us through Micra clinical review. Dr. Epstein holds more than 25 years of experience, where his clinical and research expertise has span creation and evolution in the field of invasive cardiac electrophysiology. He's been a pioneer of many procedures that are now routinely performed, such as catheter ablation, use of intracardiac echocardiography to guide procedures, implantation of cardiac devices such as ICDs, and many more. He's also one of the principal investigators for Marvel 2 study that led to Micra AV. We welcome you, sir.
Thank you very much, and thank you for inviting me and have the opportunity to visit India without the jet lag, I guess. Now, who's going to be running the slides for me? Do I go to my screen, or is it on yours, Todd? Do you know?
I just ran it on my screen, so I just shared from my own screen.
Okay, I had sent my slides in. I'm sorry. Let me.
I can share them for you, sir.
Okay. Great. And I'll just let you know to go ahead. So I'm Larry Epstein. I'm here in New York. I had the the good fortune of being involved in the Micra AV early on, not only in some of these early clinical trials where we did download studies, but I think I was the second in the world to implant a Micra AV in a person. Next slide. These are my disclosures, and let's go to the next slide. So you saw this slide before about the data of how this came about. I would just like to add, Todd has done, and his team has done an amazing job. I think the idea that you could use the accelerometer to track atrial contraction in the ventricle is really a brilliant idea, and really has taken this to the next level. I just want to say, you saw a lot of things that Todd just presented in a fairly short period of time, different ways of thinking about pacing that we usually don't think about. So it may seem a little confusing or overwhelming. It really is pretty straightforward once you have time to sit down with it. And my experience is, I can sit through a lecture about all this stuff or read about it, but really, the way to learn about it is when you're at the program or kind of playing with this stuff. It's pretty intuitive and it makes sense. And the other thing I want to say, I know there's going to be a couple of talks in a Q&A period about, patient selection. And I think the important thing to remember with this device, if you and your patients are going to be happy with using it, it's not a dual chamber pacemaker. So if somebody absolutely has to have AV synchrony, we'll talk about a little bit that you can't be 100% sure that this is going to provide them the level of AV synchrony that they need. And that's particularly true in young active patients, as Todd talked about. As the heart rate increases and the RR interval shortens, the ability of the device to track the atrium becomes much more challenging. So in young active people, there can be real limitations of this. So I think if you choose the right patients, it's really an amazing technology. I am going to focus my part of this meeting on the pivotal trial, Marvel 2. We'll go to the next slide. So this study was published a couple of years ago and led to, at least in the United States, the FDA approval of this device, even though it wasn't in the actual Micra AV device. Next slide. So the goal of this was to look at the Marvel 2 or the Micra AV algorithm. And how we did that was we took patients, as Todd just told you, with existing Micra devices, and we downloaded the AV software, the Marvel 2 algorithm, into the device. One would ask, well, why can't we just do that with our existing Micra VR patients? Can't we just upgrade them without having to put an AV device in? And the answer is no. This puts kind of an excessive battery strain on the VR because it wasn't built for this. And so if you uploaded it and left it, you'd run the battery too quickly. So it really did take the redesign of the Micra AV to have this be long-term. That being said, uploading it for a 4 to 6 hour period while we did the study didn't have an excessive battery strain, and that's how the study was done. So the primary objective was to question, does this work? There was this great idea. There was the data that we saw from the preliminary studies that it should be able to track the atrium. But what happens in a subset of actual patients? So you wanted to demonstrate that you increased AV synchrony using the VDD mode versus VVI patients that had complete heart block and sinus rhythm. Obviously, we wanted to make sure it was safe. If it was undersensing, we wanted to make sure there weren't long pauses. And if it was oversensing, we wanted to make sure that all of a sudden the device wasn't pacing at 120 beats per minute. Neither would be good. The secondary objective was to see whether there was hemodynamic benefit of VDD pacing versus VVI pacing, which kind of makes sense. If you have AV synchrony, you should have better hemodynamics looking at LVOT, VTI. Next. So what we looked at was a series of patients, 75, who we downloaded the software. Those that were evaluable to meet the primary objectives had to be patients at the time of the study who were in sinus rhythm and had heart block. So you could actually test the algorithm. So that limited us to the 40 patients who we did the analysis in. You can see that they tended to be older patients in their mid-70s. The time since implant, these were chronically implanted devices, although some could have been the day before. We had a good representation in the 40 patients. Gender was pretty much half and half, men and women. A fair number of them did have hypertension. A few had atrial fibrillation, diabetes, coronary disease, and COPD were less represented. Next. So here's what you see when the programmer up and the screen is going on. This was actually from a patient that had AV block, and you can see the first line is the ECG, the second is what the atrial is seeing, and then you see the ventricular signal. And what you can see is the VE on the top marching through, and that's the end of the ventricle period where you start sensing. And then you see the the atrial sensing signal and the ventricular pacing signal. And you can see here that you have good tracking where there's a P wave right before every QRS. The relationship seems to be pretty stable. So this would be a great example of restoring AV synchrony in somebody with heart block. Next slide. Well, one of the things we wanted to check for is what about people that had intermittent heart block? Could the device, function? And one of the things that the device can do is very similar. I think everybody's familiar with the MVP mode that we program into most of our patients who we want to promote ventricular sensing. And every now and again, the device looks for conduction if it's pacing, and you can see a drop beat that can occur. And that's kind of what's happening here. So on the left of the screen, you can see that there is AV synchrony due to A sensing and V pacing. In the middle of the screen in white, there is that mode switch logo, which says, I'm going to stop tracking and see if there's intrinsic conduction. You can see there is a P wave and no QRS right after it. The device kicks in with a pace beat, so there's no pause. It mode switches back and it starts pacing again. So it can do this on a regular basis in people that have intermittent AV block, so you're not forcing V pacing all the time in somebody that has intrinsic conduction. Next slide. And here you can see again where you have restoration of AV synchrony, where it again starts tracking the atrium and gives you good AV synchrony on the right of the screen. Next. Another example of switching to the VDD mode in someone with intermittent heart block. If you look at the ECG, there is AV conduction on the first 2 beats. You can see that there's essentially 2-to-1 block develops where the P wave has a drop QRS followed by conduction, drop QRS, conduction. The device senses this and begins tracking. And on the right of the screen, you can see good AV synchrony with A sensing and B pacing. So this is one of the nice features. Obviously, we would think this would work well in people that have complete heart block all the time, where this isn't an issue. But this allowed us to understand that actually the mode switch algorithm allows us to use this in people with intermittent AV block also. Next slide. So the primary endpoint was % of AV synchrony. So we were hoping to see greater than 70% AV synchrony, and that it was going to be significantly greater than patients in VVI pacing. You know, in my mind, this was a pretty low bar if this algorithm worked at all. Obviously, the degree of AV synchrony, if you're VVI pacing, is going to be really, really low. And if the algorithm worked at all, it was going to be much better. And that's what we found. If you look on the graph on the left with all the patients, you can see the kind of the median AV synchrony for VVI pacing was about a quarter. You know, the fact that the QRS might occur after a P wave just by chance as the P waves were marching through. And on the right of the screen in the VDD mode, you could see that we had AV synchrony in about 94% of the cases, which is really outstanding. The other thing that we did in testing the device was we didn't want to just look at patients lying down. You know, since it was dependent on how the accelerometer in the device functioned, the question was, is there going to be a difference when the patient is on their side, when they're sitting up, when they're standing up, and when they're walking and moving around? And what we found was it maintained greater than 70% synchrony regardless of postural maneuvers, that the device was able to tell where it was in space and still adjust and track the atrium, which we found very encouraging. Next. We said one of the other endpoints was, did it improve stroke volume? And not surprisingly, if you have AV synchrony, you're going to have a higher increase in stroke volume. We know that AV synchrony alone is probably not the biggest component of increases in LVOT, VTI, but it certainly does have an impact on it. And we saw that there was a significant increase with VDD pacing over VVI pacing. I think this was a given if the prior slide proved to be true. If we were achieving AV synchrony, the expectation was that this would improve, and it did. Next. Well, one of the other things that we noticed was, and not surprisingly, was that the sinus rate decreased once the patient had AV synchrony. So because there is a compensation for the fact that you don't have as much cardiac output when you have asynchronous ventricular pacing, the sinus rate increases. We see that all the time. Patients show up in the emergency in heart block and have, let's say, a junctional escape, and their sinus rate is significantly faster than when we pace them. So it's a compensatory mechanism to try and make up for that lack of AV synchrony. And you can see here that the sinus rate decreased significantly in patients who achieved AV synchrony as well. Just another marker that having AV synchrony is physiologically better than not having AV synchrony. Next. So the primary results from the study, mode switching and automaticity, the patients remained in the VVI 40 mode during periods of intrinsic AV conduction and appropriately switched. So we were able to demonstrate that the mode switch worked. Activity mode switch showed appropriate pacing support during a hall walk. So we got people up and walked them around, and were able to show that if their heart rate should have been higher based on rate responsiveness, the device appropriately switched, as Todd had talked about, and that the automatic algorithm was effective in choosing and adjusting most of the detection parameters throughout the study. I will tell you, having been involved in the study, and now being involved in putting a lot of these in, you know, right out of the box programming is not always great. You know, a lot of our Medtronic team has gotten very expert in making some very quick adjustments at the time of implant. There are some patients we have to bring back and further tweak and adjust it. But overall, the automatic detection is good. I know that in the next iteration of this is something that Medtronic is working on very aggressively to perfect the algorithms to make it much more out-of-the-box friendly for those of us who implant these devices. But it works remarkably well in a lot of patients and often just requires minor adjustments. As Todd said, just kind of adjusting that A3 window to make sure that you're not impinging on A4 is probably the biggest one. Next. Most importantly, you know, I guess second importantly was, you know, to achieving AV synchrony was it safe? And there were absolutely no pauses observed. We put Holter monitors on all these patients. So we looked at every beat in every patient when we put them in the VDD mode. There was no incidences of oversensing due to tachycardia observed. Some of the adverse things related had nothing to do with the algorithm. And so there was nothing, no adverse events due to a lack of AV synchrony or oversensing or undersensing. Next. So basically the conclusions of the study were that the accelerometer-based atrial sensing with this novel algorithm greatly enhanced AV synchrony in patients with AV block over a single chamber pacemaker. It led to significant improvements in stroke volume, and AV synchrony remained greater than 70% despite moving the patients around in multiple positions. The AV conduction and activity mode switch performs as it was intended, and there were no adverse events. And so based on these findings, the FDA went ahead and improved the next iteration of the Micra AV that we now are implanting in patients. Next. Obviously, there were limitations of this study that we had to bear out in the real world once we were putting this in people for the long term. It was an acute download study, so we were looking at people in clinic for 4 to 6 hours. We weren't looking to what happened to people over days, months, and years with this algorithm. It was a small number of patients overall. You know, assessment of the predictors of the A4 amplitude were performed in patients already implanted. So these were chronic devices, and it's unclear if chronic ventricular pacing may have changed things or other unforeseen things. Obviously, validation in a larger population with longer-term follow-up is required, and I think Todd referred to some of the ongoing studies, some of which we're a part of, to really look at how this performs over time. Next. Todd actually touched on this, which makes my life easier. We looked at predictors. You know, one of the things that we have found in clinical practice is for the patients who this works really well with, it's great. For the patients who it doesn't work for, there have been cases where we've had to decide to upgrade people to traditional transvenous patients because it just wasn't working right. Now, that's the minority of patients, but in an ideal world, you would like to be able to predict who those people are before you put the device in. Next. So just to go through this was part of Marvel 2, where we reprogrammed the devices. We already talked about, you know, the patients in this. Next slide. And these were the variables. I'm going to skip this because Todd just presented it. You can skip through this. Basically, the conclusions were that measuring ACE and EDA ratios were associated with A4 amplitude. It may be a predictor. We are looking at this moving forward. You know, one of the things people thought about, well, is there a place I could put the device in the ventricle that is going to make it better sensing the atrium? And we really haven't found that. I will tell you, not really part of this study was, for me and for many of us who have put this in, the biggest predictor is heart rate. So, you know, for me and younger patients who present with heart rates in the 80s or 90s, and they're going to exercise and get their heart rate up to 110, 120, 130, this is not a great device. in people that might have intermittent heart block where it's not going to be pacing all the time, or even in some patients where it just needs to kick in, that's fine. What I've found in some patients that I've put this in that have higher heart rates, I've achieved better AV synchrony by putting them on beta blockers and slowing their sinus rate. But I will tell you for us, and I don't know those people on the call, your experience, I suspect it's not dissimilar. Every Friday afternoon, 1 or 2 people roll into the emergency room with complete heart block, and they're 80 or 90 or even 100 years old. And for this older population that present with heart block, I think this is an enormously great opportunity. It is simple to put in, as those of you who have been putting in Micra, most procedures take 10 minutes or less. Often these patients are frail. We have a lot of little old ladies that have no soft tissue or no place to put the device, or even getting access is challenging. You don't have the issues of device erosion or pocket infection, and it seems to work quite well in that population. And I know, there's going to be more discussion about patient selection, but I think that is a really, really important part of the Micra AV rollout for everybody to have a good experience with using it. Let's go to the next slide. So I just wanted to present a case that I had just done a couple of weeks ago, and it was Micra AV to the rescue. So the patient was a World War II hero who was born on July 3rd, 1917, which makes him 104 years old. He had a previous pacemaker implantation for heart block. He had a generator change where he had dehiscence and infection, and because of his age, the folks decided to use a conservative management approach with debridement and antibiotic therapy, but unfortunately, he came back with recurrent dehiscence and Pseudomonas infection, so that conservative approach really wasn't working. Next slide. This is what the pocket looked like. Hopefully nobody's eating dinner. I don't over there. It was pretty gross. So we talked to him. He was completely functional. This guy was amazing. His wife walked into the room who looked like she was like 75 and she was 100. And the decision was made to place a Micra AV and extract this system. Next slide. So here you can see the Micra AV being put in place. We had a nice septal location. And then next slide. You can see in him, this is a laser sheath, but once we freed them up top, the leads came out fairly easily. You can go to the next one. And we're able to get everything out and allow the wound to heal. So I suspect, I can't prove it, but this may be the oldest patient to ever go implantation of a Micra AV, and it may be the oldest patient to ever undergo a lead extraction procedure. Next slide. So here's a picture of him during World War II with the arrow. So he flew 50 bombing missions over Europe during World War II. And this was him receiving in France, the insignia of Chevalier, the Legion of Honor, their highest military award. And this is the patient and his wife, who is now doing quite well with his Micra AV. On that note, I'll stop. And again, thank you for allowing me to participate in this.
Thank you, sir. It indeed was a very detailed clinical review for us. Thank you very much. Now, I would like to call upon our esteemed panelists for this evening. And our first panelist for the evening is Dr. Vanita Arora, Senior Consultant Cardiac Electrophysiologist and Interventional Cardiologist at Apollo Hospital, Delhi. Ma'am holds experience of over 25 years in cardiology and 20 years in cardiac electrophysiology. She has been the pioneer female cardiac EP in the country. She was the first to do live Micra transmission in India too. She also is the principal investigator for many cardiac devices, drugs, EP clinical trials, and research papers. She's got wide experience in conduction system pacing, 3D mapping, RF ablation, and device implantations. Ma'am has implanted over 50 plus Micra VR till date and has proctored for Micra throughout the country. Welcome, ma'am. Now, I would like to invite the second panelist for the evening, Dr. Viveka Kumar. He is Principal Director and Chief of Cath Labs, Pan Max Hospitals, Max Healthcare Hospital, Delhi. Sir holds an experience of 25 years in cardio and 20 years in electrophysiologist. He has performed 50 plus Micra in India and is also been the pioneer in leadless pacemakers, TAVI, CRTs, 3D ablations in the country. Sir is also a recipient of multiple awards, including Chikitsa Ratna, Vidya Ratna, Dr. K. Sharan Cardiology Excellence Award. We welcome you, sir. I would also like to invite Dr. Epstein to please be moderating the session for us. Thank you.
More Zoom fun, have to unmute. Well, again, thank you for allowing me to participate in this. Vanita, I was wondering if you would like to start with the panel discussion.
Dr. Lawrence, thank you so much for this honor. And I really enjoyed your talk a lot. It has been a beautiful representation of this technology, which we have been waiting since a long time to have the AV Micra available for our patients, especially for the indications that we are just going to discuss. So I would like to start the discussion by asking a very basic question, which is the ideal indication for Micra device, according to you? Should I start with Dr. Lawrence or should I start with Dr. Viveka?
Well, we can start with Dr. Vivek if you have thoughts about this. You've all just heard me talking for a while, so I'll be quiet for a moment.
Okay, thank you, Dr. Lawrence. Okay, over to you, Dr. Viveka. What do you think is the ideal indication for a Micra patient?
Yeah, so I think one which Dr. Lawrence has just shown would be the best situation, that case where you did not have any other option. So I would say that there are situations where you do not have any other option, and that is like the patient has no access, the other multiple infections and all those things. So their Micra would come very handy. So that is one situation. I think me and you would have put, at least 5-6 patients who had multiple device infections and all. But beyond that, in de novo cases, I would say the patients who have, so where, if you ask me about Micra AV, so then obviously the patients who are not very young, who do not need very active life, but they need an AV synchrony. So there I would presume that this would work. But the old Micra system, the non-AV system, the, first generation Micra, if I can say that, that would be typically those were classical indications for ventricular pacing alone, VVI pacing or VVIR pacing. So I would say that anyone who has got atrial fibrillation and doesn't need dual chamber pacemaker, so that would have been the ideal candidate. So I think it's a great boon to have this, as I think in other situations, if you had put what Dr. Epstein has shown, the case that you put the patient on temporary pacing, extract all the leads, and the OHF has to be on temporary pacing for almost a week or so, and then also they're not sure about treating the infection completely, and the second device might get infected. I think this is the situation which is Micra has made our life easy. But I would like to hear from Dr. Epstein that from trial to real life experience, what would be his take on indications of Micra and Micra AV? Dr. Epstein, over to you.
Sure. I mean, to speak to one of the things you just said, we're a big extraction center. We do, over 200 extractions a year. And very early on, just Micra in general, we published a paper in Heart Rhythm a year or so ago, thinking about why we think Micra is resistant to infection. One of the reasons it's small and has a very small surface area. It's coated with something called parylene, which has been shown to resist bacterial colonization. Interestingly, you never touch it, right? Because the Micra comes loaded in the catheter, and no matter how sterile we are, there's probably bacteria get on our hands. There's no pocket to get infected. And I think importantly, if you look at people that have endocarditis and where vegetations form on the lead, it's almost always in the right atrium, not in the right ventricle. And I think turbulent flow prevents bacteria from sticking to the device. Worldwide, there's been over 100,000 Micra implants, and I think there's been only 2 or 3 reports of infections ever. Based on that, we started being very aggressive with Micra implants, even before Micra AV in infected patients. So I will take patients who are actively infected, and if they are pacer dependent, I'll put in the Micra at the time of extraction, before I do the extraction. And what works really nice is that you don't need a temporary pacing wire that gets in the way when you're doing the extraction. And we've had patients who that became their permanent device, that they didn't need anything else. And the Micra AV is great because it allows us to expand to that heart block sinus rhythm population. There are a few patients that we, intended to do this, send them home, complete their antibiotics, bring them in, and if they needed a BIV or something, we'd reimplant. So using it in that population has been good. We've done that in over 40 patients now. We have published the first 17. So in that selected population of actively infective status post during extraction, it's been very helpful. One of the things that I've always found important, and I teach my fellows, is think before you choose. Being an extractor has made me a much better implanter. There are trade-offs that we make. For example, if you have a renal dialysis patient who has a high risk of infection, while a traditional transvenous pacer may be better because it can give you true AV synchrony under all circumstances, a Micra AV in that patient may be much better because, while a true transvenous pacer may be better, they may not have that transvenous pacemaker for long when they get infected and you have to take it out. So in the high risk infection patients, I think the Micra has been great, both the VR and the AV. And my experience, again, like I was talking about, being very careful in who I select the AV for, the people who I think are going to have good AV synchrony. So the older people that aren't as active, and in people in whom losing some AV synchrony, intermittently isn't going to be a big deal. So again, the 60-year-old person who has aortic or mitral valve surgery and is active and develops heart block post-op might not be ideal. For us, it's been great for the TAVR patients, the patients who develop heart block. We've had a number of patients who had pre-existing right bundle, left anterior fascicle block at the time of their TAVR. They develop heart block during the TAVR. Those are the patients you think are unlikely to regain conduction because they had conduction disease to begin with. And we've had some of those cases where we've just come into the OR with our structural heart folks and thrown the Micra AV in right at the time of the TAVR, and the patient walks out of the hospital the next day. So the experience has been overall pretty good, but I think we're very selective in who we use it in. If you say, oh, this is great, I'm going to put it in every patient with heart block, I think you'll be disappointed in some of those patients that really, really need 100% AV synchrony, are going to be symptomatic if they don't have it, especially if they're going to have higher heart rates. I'm interested for both of you. It's been interesting here in the United States which centers and which physicians have adopted the use of Micra and who hasn't. So I guess in India, how has been the experience with the Micra VR? Has it become fairly widely adopted? Is there pockets, or is there reluctance?
Dr. Lawrence,
Yes,
you want me to tell you the truth, or should I tell you the story which I convey?
No, absolutely the truth.
So the adaptation in India has not taken up very well. And the major reason is actually not the technical and the technology. We love the technology. It is actually the pricing. So when you are offering a patient a single chamber pacemaker with a rate responsiveness, the contrast between what the patient pays for an implant, transvenous implant, and the Micra implant is actually drastic. So what I have seen is that we have selectively, uh, kept Micra only for patients where there are actually no other options available. Like the example that you gave, I have done a lot of cases with infection. I put in a Micra just recently in a very young guy, 38-year-old patient with a congenital heart disease, post-op for DORVPS, VSD, and he had implant done couple of years back. He developed infection in the pocket. Then again, he had a replacement to be done for ERI, again developed an infection. So his sites were all gone. And young guy given a Micra. So such are the cases which we have selected to implant. The second group of patients where we have been implanting Micra are the patients who have CKD. They are on dialysis and they do not, their access is a problem because of the shunts that have been made for dialysis. So those are the patients where we have done Micras a lot. But apart from that, if you say for a typical indication, as Dr. Viveka said, for sick sinus syndrome with atrial fibrillation and slow heart rate, we have hardly used Micra in these patients because of the pricing. That is a big issue which is there. Viveka, you want to add something, please?
Yeah, so I think I fully agree with Banita that the price is a big barrier. So it's not taken off as well as it should have. And probably it's underutilized. But I would say that the biggest problem was pricing. And now, once the Micra AV has come, probably, because if you look at the number one indication for implant, unlike the other countries in India, is not sick sinus syndrome, it is the high degree AV blocks.
Yeah.
And probably, there was a inhibition that, you are not doing justice to your patient. So probably, and then obviously, as you would know, that high degree AV blocks are more in, 60 plus age groups and elderly patients where they don't really need very high heart rate. So probably most of them will be indicated and will fall in that bracket. And now I think more and more people after the COVID pandemic are taking, insurances, and also probably more people would be able to afford. So penetration might increase in near future. That is my take on this.
Yeah, I mean, we've been very fortunate in the United States that, in our Medicare population, so that's the government-run healthcare for people over 65, that and it will always change because they always pay less and less over time. But in the current situation, the hospital actually makes out better when you implant a Micra than a standard pacemaker. So we have the luxury, and I do consider the luxury of deciding what we think is best for the patient in this situation where cost becomes less of an issue. Hopefully, once this is out there, we all know, I know Medtronic doesn't want me to say this, once there's competition, the price will come down.
Pricing will come down, right.
And I think it because for us, just for so many different reasons, although putting in a single chamber pacemaker doesn't take very long, you can do it in under a half hour, most cases. Putting in a Micra takes under 10 minutes. I've done probably about three or 400 of them now. And it's just, it's the technology is great, and how the delivery system is designed. It really, I also, teach people here in the States how to put it in, and it really is a pretty straightforward procedure. The other area of interest for the Micra, which we've done, is tricuspid valve disease. So the tricuspid valve is kind of the forgotten valve, right? Everybody, we all worry about aortic stenosis now that we have TAVRs, and people have been working on the mitral valve for years, and people kind of ignore the tricuspid valve. And we know that pacing has an impact on the tricuspid valve. As an extractor, I not often, but often enough, have patients referred that have significant tricuspid regurgitation and have leads in place, and they say, hey, can you take out the leads to fix the TR? Most cases, unfortunately, people put in the leads through the valve, or it's so adherent to the valve that when you take the lead out, it usually doesn't fix it, and it can make it worse. Or the lead has been pushed against the septum, for example, for so long that even when you take the lead out, it still stays there and it doesn't fix it. With the advent of the development of new tricuspid valve technology, right now there's a study of a tricuspid valve clip, the Triluminate study, and coming down the road is going to be actually valves, replacement valves transvenously. I think we're going to see a big need for Micras in that setting. And we've done a few cases like that. I didn't include it in my talk, but we had a nice case of somebody that had a prior tricuspid valve ring, had a pacemaker, had significant TR. We took out the lead, put in a Micra, and then they put in a TAVR in the tricuspid position to fix the TR. And it was a nice solution. So I think in the future, leadless pacing, as with every new technology, the price comes down, but we're going to see that we're going to be able to help people with tricuspid regurgitation, with some of the structural work that's being done, and having the Micra available to us is helpful. There are a lot of questions there's a few questions here in the chat. I think we've addressed some of them around who are good patients. Again, I think the older patients, without high heart rates, the people who we worry about the risk of infection, either because they're low BMI, not a lot of subcutaneous tissue, risk of erosion, and then the high risk infectious patients like the renal dialysis patients, the patients who have venous occlusion, who really don't have much of an option. I have another case I didn't show here of somebody who had multiple endovascular grafts that were infected, had pacemakers that were infected, but because he had grafts down in the groin region, the referring center wanted to take out his pacemaker, which was infected, and give him a Micra, but both his femoral veins were occluded. And what we ended up doing, we put in the Micra through the IJ from above and took out his leads, and were able to help him that way. I think that, there's two things, I think, the way to think about this. There are these difficult patients where you really don't have a lot of other pacing options. And, now having the Micra AV as opposed to just the VR allows you to get better results in these patients who have heart block and sinus rhythm, where you really want to try and keep AV synchrony. I think over time, you will also see that it really is the right option as the first option for people who are also candidates for a transvenous device. And again, people who you worry about, the issues of having a transvenous device and having a pocket under the skin. There are also some young patients we put the Micra in, people who have a very intermittent need for pacing. The sudden AV block, but it's not there all the time. Or even these, hypervagal people where, as an extractor, I've gotten referred, I don't know how many people in their 40s and 50s, and it's often young women who in their teens and 20s were having recurrent syncopal episodes, and somebody did a tilt table test or a monitor, and they were having pauses and bradycardia, mostly because this was neurocardiogenic syncope or vagal, and they got pacemakers and never really needed them and outgrew them. Yeah, and now are no longer having those episodes, but now they have chronic leads and all the issues related to that. Where in that population, if you have no other choice and you have to give them pacing support during those short episodes, the Micra is actually a reasonable option, and then you don't have all the issues with chronic leads to be involved.
So I have a question, Dr. Lawrence, and I think the Todd would also help in this, that, do you have any algorithm or screening test before the implant? You can guess that who would respond better for the Micra AV?
So we are looking at that now. So the data we presented in the Marvel 2 study was a very, very, very limited number of patients. So part of the ongoing in the United States post-approval study, and in Europe as well, is to try and get this data. So we're taking a subset of patients and doing all the echo parameters. You would think echo would be helpful. one of the things we do in our lab is, usually you get an E&A ratio, but that's for the mitral valve, right? The standard way you look at an echo, the E&A is reported for the left atrium, the left ventricle. So we ask our sonographers in these patients to do it for the tricuspid valve, because obviously that's more pertinent to what we're looking at. And there does seem to be some suggestion, which makes sense if you're getting that good pressure wave from the atrium, that you're going to see it. That being said, I can't tell you that I would or would not place a Micra based on that decision making. I think for me, currently, it's what's the sinus rate and how important is 100% AV synchrony. So in older, less active patients, they tend to do fine, even if they're not 100% AV synchrony. But in younger active patients, they tend to know the difference. The other place where leadless pacing is limited is obviously in LV dysfunction, where you have to make a decision in whether you're going to give somebody a CRT device, or now, we do almost every transvenous pacemaker I put in the ventricle, I put in a 3830 lead and do either his bundle pacing or left bundle pacing. I don't spend a whole lot of time trying to get perfect his bundle pacing, because in my experience, non-selective his bundle pacing is as good as selective his bundle pacing. And I think maybe even better, because you don't run into the issues of these threshold rises and things like that. And, for me, the ideal EKG with that approach is they look like they have WPW with a septal pathway, right? That there is that kind of slurring delta wave looking upstroke, and the QRS is still relatively narrow. When I achieve that, I feel good. I feel like I'm clearly getting into the His-Purkinje system, but I'm also capturing some ventricular myocardium for safety. So there is decision making, right? Sometimes that we have to make, okay, here's a patient. What's the advantage of the Micra AV, for example? Well, it's easy to put in, there's no leads, there's nothing under the skin, but you're giving up, potentially physiologic pacing with his bundle pacing, or if somebody with reduced LV function, if you're going to put in a BiV system. I will tell you that I have been able to sometimes put the Micra high up on the septum in a spot and get an incredibly narrow QRS. And that's great. And we all say, oh, look at that, isn't it great? But I wouldn't say I can predict who I'm going to do that in and count on that being the outcome. So I think, the decision making, especially for you, given, the patients who aren't insured and where price is an issue, there's a lot that goes into it for me. I think the predictive stuff isn't there yet. I'm hoping within a year we'll be able to come back and say, look, before you make a decision, these are the tests you should do. And maybe we can have an algorithm where it includes things like heart rate, EDA ratio, the ACE based on the TAPSE that we saw, or some other clinical predictors where you could, have a score where you say, we think, if you have a score greater than 5 or whatever, I'm just making that up, that this person is going to have a very high likelihood of having good atrial tracking. And if it's less than 2, don't put in the Micra AV, because that's not going to be good. We're not there yet, but hopefully soon we'll have that. So ultimately that will help us decide. But then I think, would the patient be better served with physiologic pacing, either a BiV or a Purkinje system pacing? All those things kind of go into the decision now. But having this available, especially for these difficult patients where you either can't do transvenous pacing and your only other option would be an epicardial lead, or high-risk patients, it really is a game changer for us. It makes things much simpler.
One more question, Dr. Lawrence. From your talk and from the Marvel's trial, Marvel 2 trial, we tested 70 patients with existing VVR devices for the A4 notch on the accelerometer EGM, what we were getting. Now, having tested in the patients who already have a VVIR pacemaker, a chronic implant, which is there, why is it that we are not able to upgrade those patients? Why it is not so, except for battery issue, I understand that what you've said, but apart from that, why not?
Todd, are you still on the? I'll let you take that one.
Yeah, I mean, unfortunately, the current drain is about 150 times normal. So well, there's regulatory reasons why we need to get approval, but it basically turns the Micra from a 10-year device to a 3-week device. So it's a dramatic reduction in longevity. And so typically the microprocessor in the device goes to sleep in between every ventricular event. And in order to do that Marvel download, the microprocessor had to be on 100% of the time. And so unfortunately, it increases the current drain 150 times basically. And so if you do the math, it turns the device into basically a 3-week device. So it's just not really functional. And so that's what we had to do with the Micra AV, where we had to do a considerable amount of work, changing the electronics to process that accelerometer. So instead of doing it in software that like we're doing in the Marvel 2 study in the Micra AV, it's all done in special purpose hardware that can be done very efficiently. And so unfortunately, that upgrade just from a longevity perspective just doesn't, isn't very feasible.
Thank you, Todd.
We asked them the same thing.
Yeah.
Yeah, it's sad, but it is true.
Yes.
Yeah, it's unfortunate, but it's actually whatever. It was really amazing that we were able to because it was never designed. The accelerometer was designed for rate responsive pacing. It was designed to filter out all the cardiac components originally, and then as we started learning, like, oh, we can use this accelerometer signal, and then we were able to by doing this software. I mean, it was actually a real question whether we'd be able to pull off the download study because of whether it would be capable of doing it. And luckily there was enough flexibility to be able to do it for this, 3 or 4 hour period. But unfortunately, just the current drain's too high for chronic use.
So Todd, who first came up with the idea, the thought, hey, maybe we can use the accelerometer to track the atrium? Because that was pretty cool thought.
Yeah, I guess I was one of the people. We were always trying to like this, VVI is not the end goal, right? We need to give this for, the other patients other pacemaker populations. And so we looked at the first thing we looked at was, can we do it electrically? So we built devices with little tails on the end, right? But then that didn't make any sense with having a leadless pacemaker with a lead on the back just to do it electrically. And then we started looking at these signals in animals, and it's like it looked fairly encouraging. And so that's the sensor we had. So we also looked at, we had some old Chronicle data that we were looking at pressure, but that would have been a much more difficult system to build a pressure sensor. And we already had an accelerometer. And then, we started looking at it in humans, and the signal actually looks better in humans than it does than in most animals, because I think there's a little bit of diastolic dysfunction is actually kind of good for this signal, because it doesn't, the A3 is not quite as strong in those people with a little diastolic dysfunction. So a little less compliance in the ventricle actually can be kind of helpful here.
Well, and that kind of nicely dovetails with at least our population, that we love this in. So when we get these little old ladies who all seem to have a history of hypertension, who show up at 88 and are in complete heart block, it's such an ideal device for them. It's they're often tiny and there's no tissue here, and even at 88 they don't like the idea of having something there under the skin that can be seen, and it's such a simple procedure that and putting it in, and letting them go. You know, as far as the implant goes, I don't know how many people on the meeting are current Micra implanters or not, but you know, importantly, you know, the delivery device was designed for placing the Micra in the apex. So when you curve it down, it likes to go towards the apex. And obviously, we learned early on that that's not ideal. You know, you can increase the risk of perforation, and pacing on the septum is better anyway. And so what, in my experience, you know, the easiest and the best way to implant, you know, one of the things that the Micra implantation, and actually to put it in cadavers that we had a chance to do and in the live animals and see with the video what it looks like, has helped me with my catheter skills too. And this is something you teach the fellows, right? If you put the catheter in and you're trying to clock it or counterclock it, and you're in the ventricle, it's not moving because it's stuck in trabeculi. And the idea isn't to push it forward or clock or counterclock, it's to withdraw it, right? And get it free, and then you can move it. So my experience with the Micra is true, that if you curve it and advance it in, it tends to go down towards the apex, but into the trabeculi. So then when you try and clock it and turn it onto the septum, it won't go because it's stuck in the trabeculi. So the way I usually implant the Micra is, as soon as I get the tip across the tricuspid valve, I let go of the steering mechanism and let it go up, right? And then I start clocking it before I even advance it. As long as the tip is across the valve is when I start turning it towards the septum. And I will tell you, in 98% of the times, it's that one move straight there, you're on the septum and you're done. And you're in a really good spot. So, you know, for those of you that haven't implanted Micras or haven't implanted a lot of Micras, I find that to be the easiest way. I go in a little bit of REO projection, get the tip just across the valve, let go of the steering mechanism and clock it right onto the septum. I go to LAO. I try and go really steep LAO to really make sure I'm on the septum. Come back to REO. The other really, really, really important piece is the amount of pressure that you deliver on the catheter when you release the Micra. If there isn't good forward pressure against the wall when you deliver the Micra, it backs away and the tines don't engage. So you want to see what we call a swan neck, where you can actually see the fact that you're deforming the catheter by giving pressure. And if you're on the septum, you're okay pushing, right? You're not going to cause any problems. And if you do that, then it really becomes a one-time deployment. It's really a rare case where I have to go back and recapture it. And then the other thing, when you're checking the numbers that are very important, this is true for the Micra VR, are the AV is be patient. Just like when you use an active fixation lead and you have a big injury current, often the thresholds are high initially and they come down. The same is true for the Micra. I put one in 2 days ago where there was a big injury current on it. The initial threshold was, I think, 2.8. And literally waiting 2 minutes, the threshold was under 0.5. So be patient. And then the other things that I find predictive of a good implant is the impedance. The higher the impedance, the better. If you put the Micra in and your impedance is 200 or 300, that's often a sign that you don't have good contact. I don't think there's been a case where I've had the impedance over 800 or 900 where I've had to reposition it. So it all has to do with the forward pressure that you apply when you deliver it, allowing for that good contact. So, I mean, those are the things, whether it's the VR or the AV, that I think improves your chance of success on one deployment and getting in and out and being done quickly.
I think we have overrun the time, but it was a very interesting discussion. I really thoroughly enjoyed interacting with you, Dr. Epstein, and of course, Viveka is always a friend, and it's a very, for your information, Dr. Epstein, till about a week back, we both were colleagues. I just moved out to a new place, but we have had excellent 12 years of association, and we've been working together in a very healthy and a good environment. So I already miss working with him,
And again, I really thank you for inviting me. Hopefully in the not too distant future, we can actually do things like this in person.
Sure. Absolutely. Looking forward for that. Over to you, Meghna.
Thank you, ma'am. Thank you, Dr. Epstein, and thank you, Dr. Viveka, and thank you, Dr. Vanita. It was indeed a very enriching discussion. I would encourage the audience to please post their questions in the chat box, in the Q&A box, and we will get them answered. Now, I would like to introduce Dr. P.K. Hajra, the head of Department of Cardiology, Director of Cardiac Cath Lab, Umri Hospital, Kolkata, to be sharing his experience on Micra. Dr. Hajra holds over 25 years of versatile experience in many branches of cardiology. He is one of the first and highest implanters of Micra AV and VR. Sir has also implanted more than 70 plus Micras all over the country, right from Guwahati to Chandigarh to Cochin. And he's been the Micra proctor and trainer for Medtronic. He's also been teaching and training fellows in national and international platforms. Sir has got a wide experience in device implants and has well published in peer-reviewed journals, including a journal where there was an interesting Micra case performed by Sir in a 9-year-old. We welcome you, Sir.
Thank you. Can you hear me?
Yes, sir.
Okay. So today's discussion will be a leadless pacemaker, not necessarily Micra. So the whole world is moving for a newer, innovative therapy of treating the sinus bradycardia, sixth sinus syndrome, AV block, leadless pacemaker, heart failure therapy leadlessly. So this is a new concept of treating sixth sinus syndrome, even AV block, by blocking your ganglionic plexus, that is called cardio-neuroablations at the junction of SBC and NAUDA. You can overcome the need for Micra in some group of people, especially in young people who suffer from neurocardiogenic syncope, is very effective. There is also a trend maybe for TAVR, for temporary pacemaker, like inferior MI, prolonged stay in the ICU. Some people may think of Micra, but maybe in the future we'll have bioabsorbable pacemaker, which is lidless, wireless, and batteryless. Now, perhaps there will be a time when everything will be lidless, and there will be a crosstalk between these smaller, very small, cute devices. And there are many times we have a concomitant device, like you can go with subcutaneous ICD, CCM therapy. If you have a CCM therapy Micra, there is no problem. But if you have Micra and SICD or EVICD from Medtronic, you can have interactions between Micra and subcutaneous ICD. So which one comes first? If you have a bradycardia, definitely Micra comes first. On the top of bradycardia, if you get LV dysfunction, you need CRT or a ventricular tachycardia, you have to improvise what system you go for. You go for CRT wise, completely wireless CRT in the LV, that is also leadless pacemaker. So this is my Medtronic Micra, very cute, very small, very elegant. And this has already been highlighted. This is one of the wonder of medical device which I have come across in my lifetime. And we are eagerly waiting for this Micra to come to India. And now we are happy that we got Micra AV2. It will work as atrial leadless, that is VDD leadless pacemaker. And we also have atrial leadless VDD ICD, and which is also a kind of leadless, atrial leadless CRT. We had nanostim, but because of perforation, we have forgotten. And A4 is very important. Now the question is whether this A4 can get disturbed. So this phonocardiography can get disturbed if you have an atrial lead which can whip the atrium. So better to remove those atrial leads if you are implanting Micra AV in a patient who has got existing atrial lead or atrial device. And you get this kind of synchronizations, AV synchronizations, almost to the tune of 90-95%. And those who believe that 95% is good enough, it's for them. And those who do not believe in 95%, those who may not get satisfied with 95%, it is not for them. You should go for a completely conventional pacemaker. And most of the time, we check this. This is a real patient. We check this in sitting, coughing, Valsalva, pressing the abdomen, and we could get these kind of asynchrony in one of the patients I'll show you. A large femoral vein device like Micra clip, Pascal system, etc. You introduce a small 6-friend sheath, take it out, keep the wire. If there is inadvertent puncture of any artery, better to take another puncture for the beginners, because it's a large sheath. If you do not see, if you avoid, if you do not see this kind of caution, like if you are puncturing through and through in an artery, and if you produce a big hematoma, that may need a blood transfusion. So introduce, take the sheath out, look for spot. If there is spot, abandon the puncture and go for another puncture. It can be done from right, it can be done from left. Though initially we thought it can be done only through the right, but recently we have started doing from left. Those who have bad groins on the right, or those who have fistula in the right groin, stenosis, it is very simple and usually the same maneuver you can do. Reaching RVX, remember, the Micra is fall from above rather than push from below. Never try to push Micra from below to enter the RVFX. It is always fall from above. Some people can go for RV angiogram, and for the beginners, you should always go for RV angiogram or even LAO, and that helps you. It will work as a lighthouse. And if you have a temporary pacemaker, that is that will work as a kind of lighthouse, that will pick that Micra on the outer curvature of your temporary pacemaker to the spot where it is very easy if you have a temporary pacemaker. Now, if you have a pre-existing leads or a tricuspid valve implantations, mechanical valve, you should avoid. If you have other valves like tissue valves or ring, this is not a problem. If you have interrupted IVC, there is one case done in India through interrupted IVC through a Geiger's bend, but better to go jugular. Small child, you can go jugular, and we have done one case through in a small 9-year-old child, only 10 kg, by opening the common iliac vein surgically, and the girl had 6 implants, 6 got infected, VSD, complete heart block, and there is no access. Release and capture, so this is 2 Micra, and you'll be wondering why this patient had 2 Micra. This gentleman had myocardial infarctions and anterior MI, and then he developed intermittent AV block. Later on, he developed heart failure, so we had to put 2 Micra in this patient. Now, this is the first Micra AV in my life. And this is the man who is walking, and you can see there is a plaster in his chest. So he had infected pacemaker, and with the same day in the morning, we removed, extracted the double chamber pacemaker. Then we waited for some time for the complications, and then we did extraction of the pocket. Then we sutured the pocket. On the same day, we put Micra AV pacemaker. As a professor has highlighted, the chance of having infection on Micra, as it leadless, smooth surface, and perhaps there is antibacterial mechanism, and you do not touch the Micra. These are the things where this staphylococcus, which get, or streptococcus, which get adherent when you touch this device, is very less. So he walked immediately after having Micra AV. We checked the system, putting him back after exercise, leg exercise, and 100% AV synchrony was achieved. And this is the step, and this is the second step. You put wire in the superior vena cava, then you take this multi-purpose small injection and injections. This is post-CABG, and once you implant this Micra, it goes in the apex, and if it goes in the apex, fine, but try to achieve septal, mid and lower third. You can push here, make a bow, and then it's release it. And most of the time, it is very, very effective. And 90% of time, you can get good threshold. And in 90% of time, it is less than 0.5 millivolt. And many times, it is 0.1 or 0.3. So good threshold is not a big bad pacemaker, don't anything volt. And once you're happy, then release the pacemaker. And this is the separations. And once you have the position, you can see of the shape. And these things are very elegant, elegant hooks. I would say this is one of the innovations from Medtronic. And I'm sure it took a lot of time to have this, and that made a huge difference. That is a game changer. These 4 hooks are game changer for Micra AV, and accelerometer is another value additions. Maybe future we'll be waiting for a biological pacemaker. With that, I'd like to thank for your kind attention. Over to you.
Thank you so much, sir. And I would really want to thank our panelists today, Dr. Vanita Arora, Dr. Viveka Kumar, and also Dr. Lawrence and Todd and Dr. PK Hajra for being with us and launching Micra AV with us officially. And I would also like to thank the audience to be a very crucial part with us. So over to you, sir, Abhishek, sir.
Yeah, thanks. I think, thank you so much, Dr. Hazra and Dr. Vanita, Dr. Epstein, Dr. Viveka and Todd. I think the evening delivered as much as it promised, even probably more than that. And we look forward to, working and supporting Micra AV implants in India. We've obviously taken the feedback about pricing pretty seriously. And as we always do, whatever our physicians have to tell us, we do make a point, and we'll obviously try and come back with solutions as soon as we can. With that, I would like to close this evening, and thanks again to the very patient audience for staying on, even though there was a slight delay. Thank you so much, and have a great weekend, everybody. Thank you.
Yes, thank you.
Thank you. Hello.